Hi everyone, welcome to the channel where we discuss medical topics and lifestyle. In today's video, we are talking about the differences between inflammatory bowel disease and irritable bowel syndrome. So this is going to be an interesting one. These are two that are widely used. Sometimes we think they're the same, sometimes we don't. So we're going to be talking about the differences between the two and also the role of fecal calprotectin, a test. So we're going to talk about the role of it in the diagnosis of the two and how they relate. Let's get into the video. So we're not getting into the finer details. We're just talking about the differences and the role of fecal calprotectin. We're going to talk about a really practical way of identifying between the two and go from there. So let's jump right in. What is inflammatory bowel disease? Well, it is IBD, if we're going to shorten it. It's Crohn's disease and it's ulcerative colitis. Those are the two diseases that are characteristic and that we term inflammatory bowel diseases. They are chronic diseases characterized by relapsing and remitting inflammation. That's the word you need to remember there, of the gastrointestinal tract. There's quite a lot of it happening. So it's over 6.8 million cases globally and rising. The highest prevalence is in Northern Europe and North America. Take from that what you will. So is there some Western diet influence going on there? The peak incidence is in the second to the fourth decades of life, so 20s, 30s, 40s, with another peak in the sixth and seventh decades, so in the younger and then in the older as well. So that's what IBD is. It's an inflammatory process. So that's the term you need to remember in your mind. We're going to get into symptoms in a minute, but let's first define what irritable bowel syndrome is next. So what is irritable bowel syndrome? It is IBS. So it's not IBD, it's IBS. Irritable bowel syndrome is a functional bowel disorder of unknown cause. So we don't know what actually causes it, although there are some rumors and we can get into some theories into another video. It's typified by recurrent abdominal pain or discomfort related to defecation, so pooing, with a change in stool frequency or form. It is a common diagnosis, so estimated prevalence is around 11% globally. So you have the entire planet, almost 10%, 11%. That's crazy. More common in women. And like IBD, the irritable bowel syndrome has a peak incidence in younger adults, being more prevalent under the age of 50. So that's the similarity there. Now, IBS is not something that is going to kill you necessarily. So people with IBS, they can often undergo unnecessary tests, costly tests, invasive tests like cameras up the backside to try and get to the bottom of it, whereas sometimes it might not show anything at all. So IBD is an inflammatory process and IBS is a functional bowel disorder of unknown cause. It's not inflammatory. So the two are completely unrelated. IBD is worse. Some may say IBS is not to be thrown in the garbage. It's definitely uncomfortable and impacts a lot of people worldwide and their quality of life. But IBD is the one that with more severe complications and where you end up with surgery and more medication and all those kinds of things. So these are the differences between the two. We now defined everything. So now let's talk about the signs and the symptoms and the examination of the two. So how are we going to differentiate between the two when somebody is standing in front of us telling us their story? So the first thing to do is to take the history. So the history is going to reveal a lot of important factors. Is there a change in bowel habit, especially at night? Is there urgency? Is there rectal bleeding? Is there abdominal pain? Also, is there bloating and distension? So, in general, throughout the day, is there weight loss going on? Also, something to note that's very important is family history. So, is there a family history of these conditions ongoing? Is there a history of smoking and alcohol? These are important factors, lifestyle factors that we have to discuss. Also, is there medication history? So the use of NSAIDs, nonsteroidal anti-inflammatory drugs, aspirin, proton pump inhibitors, metformin. So these are all things that can give us clues. And then on the examination side of things, are there any extra intestinal manifestations, just like the ones listed here? So the ones highlighted in red are going to most likely point us in the direction of IBD, whereas the ones in black are going to point us in the direction of IBS. Of course, these are not exclusive, but it gives us good clues into which directions we can go in. Now, if we have weight loss and rectal bleeding, for example, it can also point us in the direction of something else that's much more serious, something called colorectal carcinoma. So this is a very worrisome thing. And you can see now where IBS, IBD, and even something like colorectal cancer can overlap. And taking history and doing proper examination and investigations are very, very important. And that's where we're going to be talking about the calprotectin going forward. Colorectal cancer has its own signs and symptoms and hints and tricks where we can look out for. Please check out my other video on that. I'll leave it in the description below. But there are something called red flags that we must not miss and that point us really in the direction of colorectal cancer. So now let's talk about the fecal calprotectin test. So you have somebody that comes in to see you and you do some basic blood tests and a basic stool test and everything comes back relatively okay or a little bit unusual. So what's the next step if we're thinking that somebody has IBD or IBS? How are we going to differentiate? What's our next step after we do these baseline investigations? So what is fecal calprotectin? I've been mentioning it since the beginning of the video. What is it? So it's a protein, to put it simply. So it's a small calcium binding protein biomarker. That's what it is. It is present in all innate immune cells. So it's present in our cells. And what it actually does is it is released into the gut lumen, so into the gut, into the intestine, where the rest of the stuff goes, and it is released during inflammation. So that's what happens, and it's not broken down in the gut. So ultimately, how do you test for this? Well, it's not broken down in the gut and it's released into the gut. You test it with a stool sample. So it's a non-invasive test. It's just a stool sample that you send off to the lab. You pop it under the microscope, you take a look at it, and you see if there are these biomarkers of inflammation. What is the main use of fecal calprotectin? So as alluded to earlier on in the video, the main use of fecal calprotectin is to differentiate between IBD and IBS. So we have somebody that's come in with some of those symptoms from a second ago with certain symptoms, and we're thinking, is it this or is it that? Well, let's do the fecal calprotectin and see what's going on. So it's the main use to differentiate between IBD and IBS below the age of 60. So if it's above the age of 60, we're going to do something else. Look at the other video on colorectal cancer if it's above the age of 60. But if it's below the age of 60, this is what we're doing. A negative test excludes IBD. So it's not IBD if it's negative. It's not. If it's a positive test, it might be IBD. So it's not specific. So it can be a lot of other things. So it can be IBD, it can be cancer, it can be diverticulitis, and so on. So those are the differences between a positive test and a negative test. So we just mentioned a positive test and a negative test. Well, we need to interpret that test because the value of the test when it is positive, it varies, right? So let's interpret it in a very, very extremely simple way. So you have an adult that comes to you. He's below the age of 60, remember. He comes to you with abdominal pain and lower gastrointestinal symptoms, the one we were mentioning. So he could maybe lose some weight. He could be going to the toilet at night, for example. So what are we going to do? So we're going to do our initial investigations, a blood test and a stool test. Make sure he doesn't have an infection. Make sure his blood tests are okay. And then we're going to check the fecal calprotectin. Now, what do we do with the fecal calprotectin? So if it's below the value of 100 micrograms per gram, it is likely IBS, and we're going to treat it as IBS. If it's between 100 and 250, then we need to repeat that. It's a little bit inconclusive. It can go here or there. So we need to repeat that in a couple of weeks or maybe refer it to a gastroenterologist. If it's above the value of 250, then IBD is quite likely or some really other inflammatory process. But IBD is quite likely, and we need to refer this urgently because then you probably need to do a camera test or colonoscopy, for example, and go from there. So what is the fecal calprotectin test actually testing for? We said it's inflammation in the intestine, in the colon. So who are not the patients we are taking a fecal calprotectin test for? So we're not doing it in patients where we are suspecting cancer or with patients with an acute presentation. So if he's got acute bloody diarrhea, then we have to go to hospital, for example, if we're unwell. But so the main reason we're using it is if somebody is below the age of 60 and if we're differentiating between IBD and IBS. That's the main use of the fecal calprotectin test. And those were the main differences between IBD and IBS in clinical practice. So if you're speaking to somebody or if somebody is in front of you, or even if you have a friend in front of you and you're talking about symptoms, those are the differences. I hope you enjoyed this video. I hope you learned something. Please like and subscribe for more. comment in the section below, and we'll see you in the next one. Take care.